Good morning, everyone. Today the topic is neonatal resuscitation. Today the topic is neonatal resuscitation. So, introduction, the process of birth. It brings the fetus from the fluid environment to the air environment. So, there are many adaptations that should take place in this during this process. So, this transition is accompanied by physiological and biochemical changes. So 10% of neonates require some assistance at birth. 1% neonates need extensive resuscitative measures, and asphyxia accounts for 20 to 23% of total newborn deaths. And asphyxia is the most common, one of the most common causes of newborn deaths. Okay, so normally in case if it is a normal delivery, so the mechanism is like the baby comes out on its own. But in some around 10% of the cases, the baby needs some assistance, and 1% of the cases, the baby will require extensive resuscitative measures. Okay. So this is what happens at birth. So normally in the intrauterine period, all the fetal alveoli is filled with fluid. So when the baby comes out of the womb and first takes a breath, that is when the fluid gets absorbed and the air gets filled into it. Okay, and these are the subsequent stages. And after subsequent breaths, the alveoli is completely filled with air, and the fluid is very minimal after that. So pulmonary vessels dilate, causing increased blood flow to the lungs. So this is constricted blood vessels before birth, and then after birth, the vessels are dilated, and there is increased oxygen in the blood. So assessment at birth. So most infants have Apgar score between 7 to 10 at 1 minute and do not require any resuscitation. Infants with Apgar score 4 to 6 require some intervention, while those less than 3 are severely compromised and warrant urgent resuscitation. So any baby at birth, the normal Apgar score is around, above 5, it is the baby is good, and above 6 the baby is good, and less than 6 we need some sort of intervention, whether it is whether the baby is severely compromised or not, and based on that we need more resuscitative measures. Okay, so this is Apgar score. Please note it down. You'll have a question from this. Okay, what is Apgar score and what are the components of Apgar score? Apgar score is a neonatal assessment scoring system that is used as soon as the baby is born. So the components in Apgar score are activity, pulse, grimace, appearance, and respiration, and from this the name comes Apgar. Okay, so if the activity is absent at birth, point is 0. If arms and legs are flexed, that is there will be some kind of hypotonia, then the point is 1. But if all the limbs are flexed and good tone is maintained, then the score is 2. So pulse, if it is absent, then the score is 0. Below 100, it is 1 point, and about over 100 is 2 points. So the normal pulse rate, heart rate in a baby is around 120 to 160 is normal, but it is abnormal when it is below 100, and over 100 it is okay, it is normal. So next is reflex action, that is grimace. So flaccid is 0. Some flexion of extremities is 1 point, and active motion is grimace is present, then it is 2. So appearance, skin color, if it is blue or pale, that is the presence of cyanosis, or the totally the baby is pale, it is 0. Body is pink and extremity is blue, then it is 1 point, and completely pink, it is 2 points. So as soon as the baby is born, if you see the color of the baby, if the baby is pink, so you can actually relax. Okay, the baby is normal when it is when you see when the skin color is pink. So respiration, if it is absent respiration, the points is 0. Slow irregular respirations, it is 1 point, and vigorous cry, it is 2 points. So the total score is around 10. So if the baby is in good condition and no resuscitation is needed, if the Apgar score is between 7 to 10, moderately depressed when it is 4 to 6, and severely depressed when it is 0 to 3, and all resuscitative measures should be, extensive resuscitation should be done in severely depressed babies. Usually the moderately depressed babies, when we give little effort from our side, the babies do recover very quickly. So consequences of interrupted transition. So the compromised baby may exhibit one or more of the following clinical findings: low muscle tone, depressed respiration, that is apnea or gasping, bradycardia, and cyanosis. So antepartum risks. These include maternal diabetes, chronic maternal illness like hypertension, anemia, and hypothyroid disorders, hypo or hyperthyroid disorders, and any vitamin deficiencies. Preeclampsia, maternal infection, polyhydramnios, oligohydramnios, premature rupture of membranes. And premature rupture of membranes, it is okay if it is around less than 6 hours, it is okay, but after that there will be increased risk of infection to the newborn baby. And IUGR baby, IUGR baby is at risk baby. It is very hard to manage a IUGR baby, and these babies have multiple complications. Okay, and next is post-term baby. Post-term baby, anything after 42 weeks is called post-term babies. And they have these are associated with polyhydramnios, etc. And multiple gestation, twin pregnancy, usually the babies will be less in birth weight, and they may have anemia and other complications, and they are also at risk. And anemia, if the mother is anemic and the iron stores are less in the mother, then the baby is anemic. And if the maternal age less than 16 or more than 35 is an at-risk pregnancy. So intrapartum risks, instrumental delivery, abnormal position, and premature labor, chorioamnionitis, prolonged rupture of membranes, prolonged labor, that is more than 24 hours, prolonged second stage of labor, fetal bradycardia, narcotics administered within 4 hours of delivery, meconium staining of liquor, prolapsed cord, abruptio placenta, and placenta previa. So fetal asphyxia. Asphyxia means lack of oxygen and blood flow to the brain. So birth asphyxia happens when the baby's brain and other organs do not get enough oxygen and nutrients before, during, or right after birth. So this happens at the time of birth. So initially, as soon as the baby is born, there is a rapid breathing. After that follows the primary apnea, and after that there is irregular gasping, and then follows the secondary apnea. So fetal asphyxia, in primary apnea, the baby is apneic, blue, heart rate increases, and resuscitation can be done easily by simply by providing oxygen. The baby may improve in condition, or sometimes it will go to bag and mask and chest compressions, but the baby usually recovers easily. In secondary apnea, the baby is apneic, white, floppy, heart rate reduces and require active resuscitation, and sometimes we'll have to go for adrenal injection and intubation along with positive pressure ventilation. So equipment needed for resuscitation. So one is the radiant warmer, warm towel and blankets, resuscitation bag and mask, self-inflating bag, endotracheal tubes, laryngoscope, oxygen source and tubing, suction source. So a radiant warmer. Even before the baby is born, once a pediatrician goes into the OT, the first thing we should do is switch on the warmer and set the temperature around 35 degrees, because the baby is warm inside the womb, and as soon as it comes outside, it is exposed to the cold climate outside. So, and this should not go for long. The baby should be given a warm environment outside also. So as soon as you go inside the OT, you should turn the warmer on and should be kept on for at least 10 to 15 minutes before the birth of the baby. Okay. And warm towels and blankets. The baby should, when the baby delivers, and the baby should be wrapped in a towel, which should be a sterile one and a warm one. Okay, and we should wrap the baby in the towel, and then we should completely remove the wetness from the baby so that the baby won't go into hypothermia. So a resuscitation bag and mask. Once you see the baby, and a resuscitation bag and mask is always kept ready in a delivery place, so that if the baby does not cry, and after giving oxygen also the baby does not improve, so then we can go for bag and mask. A self-inflating bag is also necessary sometimes. ET tube and failed after bag and mask also fails to, if the baby does not take any spontaneous breaths even after doing bag and mask, and if the saturation does not start to improve, then we go for endotracheal intubation and we connect the baby to the ventilator. Oxygen source and tubing. It is given in the first place, even before bag and mask is kept. Plain oxygen is given to the baby. And suction source, it is always important to suction the baby, first initially the mouth and the nose, but for in sick cases like meconium aspiration syndrome, extensively suctioning should be done, and for that intubation is also required, and after we intubate the baby we do tracheal suction also. So as soon as the pediatrician goes into the OT, we should check for all these. Okay, first you turn on the radiant warmer and set the temperature around 35 degrees, and then you check the suction source, the oxygen. You take the necessary bag and mask, and neonatal mask. Neonatal mask as well as a pediatric bag and mask set should be ready, and ET tubes according to the neonatal endotracheal tube should be taken along with the laryngoscopes. Okay. So ET tube size, if the baby is less than 1000 kg, tube size will be 2.5. So 1000 grams. Okay, sorry. And 1000 grams to 2000 grams, that is 1 to 2 kg. The approximate gestation week will be 28 to 34 weeks, and the required ET tube is 3.0. And 2 to 3 kg, the gestational age will be 34 to 38 weeks, and the tube size will be 3.5. And more than 3 kg, gestational age will be more than 38 weeks, and the tube size should be 3.5 to 4 mm. So you should check before itself, and you should make sure that the right size of the ET tube is kept, so that if you insert a tube of lesser size, then there'll be air leaks. The ventilation will not be adequate, and anything more than the required size, that will cause harm to the larynx. Okay, vocal cords also. And laryngoscope blade, very preterm, it is it is 0, for the preterm it is 0, and neonate it is 0, or a small infant it is 0. Infant to 2 years it is size 1, and 2 to 8 years the size should be 2. Okay, so how do you intubate a baby? Before itself, you should take a laryngoscope and check if the light is good or not. You can change the lights and check for the batteries as soon as you take a laryngoscope, and make sure that you hold your laryngoscope with your left hand, and with the the ET tube in your right hand. First you keep the baby in right position, and then you keep the laryngoscope, and you get a good view of the vocal cords and the larynx. And then once you get a proper view, you put the ET tube of the exact size. Okay. So equipment needed, this is the radiant warmer. Here, this is the place where the baby is made to sleep. And this is the overhead radiant, warmer. From here the temperature, from here the heat is generated, and here you have a light on top also too. That helps in examination. And on this right, here you usually keep some the monitor in which which is connected to the baby to check the pulse rate, saturation, respiratory rate. And connected to this warmer is this, you have a temperature probe which is kept to the baby, and you keep checking their temperature time to time. And in case of any hypothermia, you increase the temperature of the warmer. And it is if the baby is, if you feel it is too warm, then you can reduce the temperature, or you can turn it off for some time. Okay. So place under warmer and dry the baby using a warm sterile towel. Use syringe to clear mouth and then nose. Tactile stimulation if not breathing yet. Auscultate heart and lungs to and assess color. So free flow oxygen is needed as needed. So once you get the baby, the initial suction will be done by the delivering gynecologist. And as soon as you take, the first thing to do is warm the baby, dry the baby, and then you take a bulb sucker. How you use a bulb sucker is you need to press it before you insert. You need to press the bulb hard before you insert into the baby, and then you insert it into the throat. Into the baby's mouth, and then release the bulb. So this creates a negative suction force, and then all the secretions will come out. So it is better if you can place the baby in a lateral position and then start sucking from the baby's mouth. And then nose also should be done. Usually if the sometimes in very mild cases, suctioning itself stimulates cry, and the baby starts crying. Okay. So, and if the baby does not cry on thorough suctioning, then we go for tactile stimulation. And tactile stimulation, usually nowadays it is done on the palm, on the legs, and then auscultate tactile stimulation, or you can stimulate on the back also by doing back rub. So, and then auscultate heart and lungs. Just check the heart rate by using the stethoscope, or you can check the heart rate by holding the umbilical stump in your hand and counting the pulsations. And the lungs for air entry, and color. Color is the most important and the easiest thing you can assess. If the baby is pink, the baby is good. Okay. If the baby is pale or blue cyanos, then the baby is sick, and then immediately rush for resuscitative measures. And free flow oxygen is needed. And the cyanosis due to lack of oxygen should not be confused for acral cyanosis. So prevent heat loss, place on warmer, dry thoroughly, remove wet towels from the baby. And if you're keeping the baby under a warmer, then it is okay if you don't wrap the baby also. You can leave the baby like that if the baby is kept under a pre-warmed warmer. Okay. And position, head of the baby should be towards you. Okay. And the first part to dry is the head, because size of the head is big in a neonate, and you need to wipe the head away first, so that heat loss will be minimized from the head. Okay. And this is suctioning of the mouth and nose. And after that, initial breathing by tactile stimulation of the soles. Okay, you just rub the soles, and then evaluate infant for breathing, heart rate, and color. So, inverted pyramid of neonatal resuscitation. First is drying, warming, positioning. The head should be towards your side. And the suction, tactile stimulation, oxygen, bag and mask ventilation, chest compressions, intubations, and medications. So this is the NRP guidelines. Note it down, you have an essay on this. So the first thing in NRP guidelines is equipment check and team briefing. The doctor goes and he has a team of 2 nurses. to whom he will explain everything, and then go for a complete equipment check. Remember, the sisters will not do, no one else will do, only the doctor should do all should check all this equipment. Okay, so birth of the baby. So term gestation, good turn, breathing or crying. If yes, the infant stays with mother for routine care, warm and maintain normal temperature, position airway, clear secretions if needed, dry and ongoing evaluation. No, if the baby is not a term baby, does not have a good tone, and the baby is not breathing or crying, so warm and maintain normal temperature, position the airway, clear secretions if needed, dry and stimulate the baby. And after that, apnea or gasping, heart rate below 100. Then go for labored breathing and persistent sign, and then look for labored breathing and persistent cyanosis. And if these are present, position and clear airway, monitor SpO2, supplemental oxygen is needed, and consider CPAP if necessary. And if once the baby is stabilized here, post-resuscitative care should be taken. So if apnea, gasping, and apnea or gasping and heart rate is below 100, start PPV, positive pressure ventilation, that is by using a CPAP, and SpO2 should be monitored, and ECG machine should be connected. Okay, and if then heart rate is below 100, heart rate is below 100, then go for chest. Check chest movements, ventilation corrective steps if needed, endotracheal intubation or a laryngoscope is needed. And even then heart rate is, if heart rate is after this, if the heart rate is below 60 per minute, so if the baby is good after this, the same thing, the post resuscitation care will be taken. And if the heart rate still falls and intubation is not already done, go for chest compressions and coordinate with PPV. 100% oxygen is required, ECG monitoring, and go for emergency umbilical vein catheterization. And after this, heart rate is below 100, IV epinephrine is given. If heart rate persistently below 60 per minute, consider hypovolemia, consider pneumothorax. Okay. So while starting bag and mask ventilation, check the size. A proper neonatal bag and mask should be, and the appropriate size mask should be taken. And in case of a preterm delivery, the appropriate size bag and mask should be taken. So as soon as the baby comes out, you clear the secretions. You position the baby, you dry the secretions, and you dry the baby, and you clear the secretions. And if the baby is not breathing, or the baby is gasping, then you go for supplemental oxygen, and then you continuously start monitoring the baby for SpO2. Okay, and then if oxygen, even after connecting to the oxygen, if the baby is still not, if the saturations is not coming up, and if the breathing pattern is not normal, go for CPAP. And after that, if the CPAP is also not adequate, if the baby is gasping or the baby is in apnea, for apnea, CPAP will be enough. But if the baby is gasping, go for PP. Go for intubation and keep the baby on ventilator. Okay. And if the heart rate is below 60, go for IV epinephrine that can be given via the umbilical stump or by a cannula. But usually at that time, you will not be able to find the cannula. You will not be able to cannulate the baby. So best is umbilical venous catheterization. So steps in resuscitation: airway. So clear airway if required, removal of secretions if present, and suction mouth and nose. Positioning supine or lateral. And the lateral position is always better because all the secretions come to one side of the mouth and it is easy to suction from that place. And head in neutral or slightly extended position. So this is neck slight extension, and keep it in mind the head should not be overextended or it should not be flexed. It should be in a slightly extended position, and in this way you'll be able to suction the secretions better, and for intubation also this is a better position. So head in neutral position. The external auditory meatus and the suprasternal knot should be in the same plane. That should be they should be horizontally aligned. Okay, you can do this by keeping a roll under the head, or if necessary under the shoulder rolls. So this is for tactile stimulation, rubbing the sole, rubbing the back, stomach. So breathing, assessment of respiratory effort and color, indications for oxygen, look for the indications for oxygen administration. And these are cyanosis, respiratory distress, and give free flowing oxygen around 5 liters per minute using a mask. Okay. So breathing indications for positive pressure ventilation, that is apnea, gasping respiration, heart rate less than 100, persistent central cyanosis despite 100% oxygen, and 40 to 60 breaths per minute, and no response. Just a second. Sorry, the 40 to 60 breaths is normal. This is not included here. And if no response. So this is a neonatal ambu bag, and this is a pop-off valve here that helps in removing the excess pressure we give. And this is an air reservoir, and this is a tube through which the oxygen is connected. So position the head slightly extended, position the mask, see that the nose and mouth are totally closed, and there should not be any gaps in the sides also, so that the air won't escape on the sides. So seal mask airtight to face with thumb and index finger on top of the mask. Squeeze the bag to move the chest gently 40 times per minute, and watch for slight rise of chest, and the normal rate should be 40 to 60. So indications for endotracheal intubation, prolonged positive pressure ventilation required, bag and mask ineffective, inadequate chest expansion. If chest compressions required, intubation can facilitate coordination and efficiency of ventilation, and tracheal suction required. So steps in resuscitation, A, B, C, D, E, and now we come to C in A, B, C, D, E. So assessment of heart rate and response to previous measures that can be done by using the umbilical stump, where the pulsations can be felt by your hand, and then by seeing the apex beat, and then by auscultating the baby. So chest compressions should be started when heart rate is less than 60, and despite adequate ventilation with oxygen for 100% oxygen for 30 seconds. And two techniques are used: two-thumb technique and two-finger technique in a ratio 3:1. And once you compress the chest, approximately one-third of the diameter should be compressed. So this is a two-thumb technique, and this is a better technique to follow because you can do it for more time. This is two-finger technique. You can't do it for more time as your finger starts to pain. So and next drugs like epinephrine, volume expanders, and naloxone in case of any drugs given to the mother 4 hours prior to the delivery. So epinephrine indications include heart rate less than 60 per minute after positive pressure ventilation, and chest compressions for 30 seconds. Route of administration is intravenous, that is route of administration is usually intravenous and sometimes can be given by endotracheal route also. And in very severe cases, if the heart rate is not coming up, sometimes you can go for intracardiac epinephrine also, but this is very, very rare. So the concentration is 1:1000, that is 0.1 mg per ml. Dose is 0.1 to 0.3 ml per kg, given via IV or UVC. 0.5 to 1 ml per 0.5 to 1 ml per kg via ET. So in ET the dose will increase. Okay, and this can be given directly, or this should be diluted with the NS and should be given. So rate should be given as rapidly as possible, and if the heart rate is not increasing, repeat dose and every 3 to 5 minutes, and a maximum of 3 to 4 doses can be given, and after that there will be no use. So this is the umbilical stump. What you see is 2 arteries and plus 1 vein. The arteries you see smaller openings, and the vein is usually collapsed because the veins do not have muscularis layer in this, and so the vein is collapsed, and the arteries have muscular layer in their. The arteries usually have the muscular layer, and so they are intact. They are not collapsed. So volume expander indications is poor response to other resuscitative measures and evidence of blood loss or suspected shock, like when the baby has pale skin, poor perfusion, and weak pulse. So crystalloids are used normally, and these are normal lactate, ringer lactate, and very, very rarely we use O negative blood cross matched with mother's blood. That is very rare. We don't usually use. So the normal crystalloid, the normal amount of crystalloid we should give will be around 10 ml per kg. Route will be umbilical or IV. So naloxone, a narcotic antagonist. Indications: a history of maternal narcotic administration within the past 4 years, and a severe respiratory depression is present. After PPV has restored a normal heart rate and color. Recommended route is intravenous, and the dose is 0.1 to 0.2 mg per kg. So meconium present in baby vigorous baby, strong respiratory efforts are present, and good muscle tone. Heart rate is above 100 beats per minute. Suction catheter or suction valve for suction of mouth or nose. ET suction not required. So as soon as we get a meconium stain baby, meconium staining is more common in postterm babies. So first we receive the baby, and the first steps are common. We position the baby, we dry the baby, and for meconium stain babies, suction should be done very extensively. A thorough oral and nasal suction should be done, and even if then the baby has increased respiratory efforts, then we intubate the baby, and using an appropriate size ET and a laryngoscope, and then we do a tracheal suctioning also. A complete tracheal suction should also be done. So insert laryngoscope, clear mouth and posterior pharynx, insert endotracheal tube into the trachea, attach the ET to suction source, apply suction as ET is slowly withdrawn, repeat as necessary until no meconium or heart rate indicates further resuscitation. So what to do if still no improvement? If no improvement seen despite all efforts, ensure adequate ventilation, chest compression, and drug delivery. If heart rate is still less than 60, if the heart rate is still less than 60 minutes, consider airway malformation, pneumothorax, diaphragmatic hernia, and congenital heart disease, and do the necessary management for these conditions. So what to do if still no improvement is seen? So infants with an Apgar score of 0 after 10 minutes of resuscitation, if the heart rate remains undetectable, it may be reasonable to stop resuscitation. So variables to be considered may include whether the resuscitation was considered optimal, availability of advanced neonatal care, such as therapeutic hypothermia, specific circumstances before delivery, example, known timing of the insult, and also wishes expressed by the family. So discontinue resuscitative effort, stop resuscitation if heart rate is undetectable for 10 to 15 minutes. Also take into consideration factors such as presumed etiology of the arrest, gestation of the baby, and presence or absence of the complications. So if the gestation of the baby is very low, usually mortality is more in our country, and in our country the minimum baby we can I mean we can resuscitate and we can resuscitate is around 600, and that is only done in high level centers and cannot be possible in normal centers. So around if the baby weighs around 900 grams, that is okay, we can manage the baby in most of the places. And presence or absence of complications, some congenital heart disease or airway malformations cannot be managed. So summary, doing simple things better is probably the most cost-effective policy. Resuscitation can come as complete surprise, so be prepared for resuscitation. It may take several hours to learn, but it should be implemented over seconds, and practice makes one perfect. Thank you. Any doubts? Please let me know. ఇదేదో వచ్చింది. అయిపోయింది. ఇది ఎవరితో ఫోటో
అయిపోయింది కదా.
అయిపోయింది.
డౌట్స్ అడుగుతాను.
డౌట్స్ అడిగారు, టైప్ చేసి.
ఓకే, ఎండ్ చేసేసి